Rahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Amira Beti Musa. My ID number is 9408030355740001. I'm from Bachelor of Medical and Health Science OUM Alustar. Okay, today I want to present you my clinical practice pre-hospital care and ambulance service. My topic is anterior hip dislocation. My clinical practice is almost 2 weeks, which is 18 August 2001 until 14 September 2001, and my clinical practice at Emergency and Trauma Department Hospital Seberang Jaya. Okay, first of all, I want to share with you what is hip dislocation. The hip is a ball and socket joint. The socket is formed by the acetabulum, which is part of the largest pelvic bone. The ball is the femoral head, which is upper end of the femur. A smooth tissue called articular cartilage cover the surface of the ball and the socket. It creates a low friction surface that helps the bones glide easily across each other. The acetabulum is ringed by strong fibrocartilage called the labrum. The labrum forms a gasket around the socket, creating a tight seal and help to provide stability to the joint. Hip dislocation is frequently injury to the hip joint when the ball-shaped head of the femur comes out of the cup-shaped acetabulum situated in the pelvis. This is referred to as dislocation. Hip dislocation are categorized as anterior or posterior dislocation based on the placement of the femoral head. Okay, this is you can see the anatomy of the hip, which is in normal condition. Head of femur stay firmly within the acetabulum. Okay, for anterior hip dislocation, it happens when the thigh bone slip out of its socket in a forward direction. The hip will be bent only slightly and the leg will rotate out and away from the middle of the body. When the hip dislocates, the ligament, labrum muscle, and the other soft tissue holding the bone in the place are often damaged as well. The nerve around the hip may also be injured. According to Jia and Chim 2020, anterior hip dislocation occur when the femoral head is displaced anteriorly. Okay, here I want to share with you a few symptoms of hip dislocation such as pain, deformity, muscle spasm, inability to move the hip, able to bear weight or stand on hip and leg will be abnormal position. Okay, now I want to present my case presentation. Pre-hospital care has received an emergency call 999 from MERS from MECC Pulau Pinang to respond an emergency case which is around accident. The accident involved a collision of two cars. A man 40 years old brought by pre-hospital care to emergency department. Patient alleged motor vehicle accident. Car versus car. On scene, what we find is this as patient I4, verbal 4, and motor 5. Patient has loss of conscious. Patient unable to ambulate or walk. Patient complain pain over right hip. Okay, here I want to share with you the demographic data, which is my patient is 40 years old, male Malay, and married. It worked as operator and the main complaint is pain over right hip. Here is the general health history, which is in my patient known case of diabetic mellitus and on medication, no surgical history, allergic to seafood, and non-smoker, non-alcoholic, or non-substance abuse. Okay, now I want to share with you what is assessment and investigation for this patient. First of all, what we do is physical examination. Okay, in emergency, we do general. First, what we see in general is patient alert, conscious, and DCS is 15 over 15. Patient no shortness of breath and no chest pain. After that, we look for the vital sign, okay, which is the blood pressure, respiration rate, temperature, pulse, oxygen level, glucose, and pain score. Okay, after that, we're going to head and specialty sense test, which is face. We look for the any bruises, and head we look for any bruises or bleeding, and eyes, ears, nose, and throat. After that, we do uh, for arms. We inspect. They are deep laceration wound with minimal bleeding over left arm, and then we palpate no tenderness. On leg, we inspect there are abrasion wound on the left knee and deformity at the hip area. We palpate no tenderness and swelling. At the neck, no injury and abnormality, no lumps. For cardiovascular, we inspect no injury and abnormalities. We palpate apex beat present, and we escorted dual rhythm no movement, and the lung patient are clear for abdomen, no scar and no tenderness. After that, we do for elementary, which is we do inspection, palpitation, percussion, and auscultation. Everything we find in patient are normal. And then we go to central nervous system, which is what we see. Patient alert. Patient can move all parts of body, and all sense are abnormal. Okay, here the table. You can see this. What we do in upper limb and lower limb, which is we look for the power, sensation, and muscle tone. Okay, after that we go to urinary, no dysuria or hematuria. On genital, no private part bleeding. And the investigation we do for patient is X-ray for clavicle, chest, less humerus, less right, left femur, left knee, and pelvic. What we see pelvic, no fracture. But over left femur, what we find is anterior hip dislocation. And after that, for left upper limb, the sensation intact, and patient able to move fingers, no wrist drop, and patient able to flex. After that, we do for the left lower limb, which is abnormalities and tenderness at left thigh, swollen, sensation intact. Capillary refill is less than 2 seconds. Okay, after all this investigation, we do some provisional diagnosis, which is patient diagnosed as a large motor vehicle accident with left anterior hip dislocation with deep laceration wound over left elbow and multiple abrasion wound. Okay, the differential diagnosis for this diagnosis we can say as hip subluxation, okay, pelvic pressure, femoral neck fracture. After that, I want to share with you what is pre-hospital care management. In pre-hospital care management, what we do is first thing is danger. We make sure all the location are clear from danger, no hazard, and what we must do in we wear our personal protective equipment. We must make sure that patient in a safer place before future assessment. After danger, what we do is respond. Call patient to make sure patient alert and conscious, and we can tap patient shoulder if patient not opening his eyes. After response, we're going to check for airway, and then check whether patient airway pattern or not, such as we can look for trachea dilated or not. We look for any foreign body inside the mouth. The patient can talk, so it was considered the airway was clear. After that, we apply cervical collar to protect the patient's cervical. After that, we look for the breathing. In breathing, we can divide for inspection, percussion, palpitation, and auscultation. In inspection, we observe how patient breathing. Look for a sign and symptom. In percussion, we listen the sound of the chest wall, whether it was dullness or resonant or hyperresonant. In palpation, we palpate the abdomen to see. After that, we auscultate to make sure the air entry for the both lungs are clear. After the breathing is clear, we going to circulation, which is we monitor patient vital sign and find any sign and symptom of shock, and then we control active bleed with the pack, uh, and then we control active bleeding and pack with the gauze, which is we found that there are laceration wound at the left arm. We check for the patient pulse volume, whether it's strong or slow, and then we check for the capillary refill time, which is the patient is less than 2 seconds. Less is than 2 seconds, we can consider it as a normal. And lastly, we do is expose. In expose, we can look for other abnormalities, and we look for the patient pain score, and we consult to MECC for the painkiller in order to reduce patient pain, and we transport patient immediately to hospital and tagging patient at yellow zone. Before we give any painkiller, we must monitor the patient vital sign. Okay, yeah, now I want to share with you what is suggestion and solution with this case. Okay, we can do close manipulation reduction, or we call CMR here. The step for CMR, and then we can do post reduction management, which is the temporary period of traction or balance suspension until the initial patient has subsided. After this, control passive range of hip motion exercise and early mobilize through to benefit the patient overall condition. Extreme of motion should be avoided for 4 until 6 weeks to allow for capsular and soft tissue healing. After that, we can do surgical intervention. In surgical intervention, we should be performed if close reduction is unsuccessful, bone fragment or soft tissue remain in the joint space, or the joint remain unstable. Hip arthroscopy can be used to remove intra-articular fragment. It evaluates intra-articular fractures and chondral injuries and repair laboratory. And after that, we can also do rehabilitation, which is relax, ice, and take anti-inflammatory medication to minimize hip swelling. Passive range of motion exercise is to improve flexibility within 5 until 7 days after the injury incident. Walking aid should be used until the patient is comfortable with the bone weight bearing and range of motion. Okay, now I want to share with you what is the complication for these cases. Firstly, nerve injury. It happens when the thigh bone is pulled out of its socket, particularly in posterior dislocation. Nerve in the hip can be crushed and stretched. Second, osteonecrosis. As the thigh bone is pushed out of the socket, it can be tear blood vessel and nerve. When blood supply to the bone is lost, the bone can die. After that, it can cause arthritis. The protective cartilage cover the bone may also be damaged, which increase the risk of development arthritis in joint. In conclusion, what can I say? Hip dislocation are common injury that result from a high energy mechanism. This patient require careful trauma evaluation to rule out co- uh, to, uh, to, to rule out the injury. Early immobilization by pre-hospital care team and reduction within 6 hours and close radiological follow-up, it is recommended to avoid serious complication. Anterior hip dislocation without femoral head injury have a better long-term prognosis than posterior dislocation. That's all from me. Thank you.